you very much. Thank you to WIROC for inviting us for giving this lecture. So, non-union neck femur is a very, very dreaded complication. It's a dreaded complication of a dreaded fracture, and usually it's the result of a very high energy trauma and requires detailed analysis and a systematic treatment. So if you think of the two main complications of femoral neck fractures, they are avascular necrosis and non-union. And we should remember the avascular necrosis depends on the intensity of injury. So the fate of the child as regards avascular necrosis is sealed at the time of injury itself. As against that, non-union many a times depends on what we do, depends on our fixation. The non-union, one of the main causes also is the fact that it is inside the joint, so it is always bathed in synovial fluid. The second is also the mode and severity of the injury with the degree of displacement. The obliquity of the fracture line makes a lot of a difference, the Powell's angle, and the method and adequacy of fixation and reduction is also very, very important. We many a times get such sort of X-rays where the fracture has not been fixed well or not even reduced well and not fixed well, and that is a sure shot recipe for non-union of the neck femur. So when I was going through literature and over time, one article which is really the eye-opener about non-union neck femur, and if you want to read any article about it, this is one article we should read. This is the Sandhu's article which was published in 2007. After reading this, I thought of this dialogue. असली काम तो ये लोग करते हैं, हम तो ऐसे ही है. Which means that this is a detailed analysis of 500 cases of non-union neck femur. This is a single center, single surgeon experience. It's an amazing, amazing work and gives detailed analysis and has classified non-union neck femur into 3 stages and 3 groups. So in all these fractures can be classified into 3, that is good, bad and the ugly. These are based on the 4 points: the fracture surface, the proximal segment size, the fracture gap and signs of avascularity. So if you know these 4, you should be able to plan your management of neck femur fractures and also prognosticate about what is going to happen. So this is a grade 1 or a stage 1 fracture. Here the fracture surfaces are irregular. The size of the proximal segment is more than 2.5 centimeters. The fracture gap is less than a centimeter, so it's a well approximated fracture, and there are no changes of avascularity. This is a good non-union. The treatment is primarily a biomechanical improvement. You improve the Powell's angle by doing a valgus osteotomy. So this same fracture, you do a valgus osteotomy and it has healed beautifully after a year. We have a group 2 or a stage 2 fracture where the fracture surfaces now start becoming smoothened. The size of the proximal segment though remains the same. The fracture gap increases. It's between 1 to 2.5 centimeters and there are still no changes of avascularity. This is a relatively bad fracture. You treat it by adding a biological stability to your biomechanical improvement. So you do a valgus osteotomy and add a fibula graft. Something like this, and this has healed up after a year. A group 3 is the worst one. You have a fracture surface which is absolutely smoothened like this. The size of the proximal segment decreases, it's less than 2.5 centimeters. The fracture gap has now increased to more than 2.5 centimeters and there may be some signs of avascularity. These are the really, really ugly ones. The treatment here is you have to improve the biomechanics, you have to give a biological strut, and you also have to give some osteoinductive input by adding a Powell's valgus osteotomy with a fibula graft and with or without some bone graft in the interim. So this same fracture can be treated like this. You can see that the fracture has now healed. We now have to treat the LLD later on. A brief note on a valgus osteotomy. So you have a Powell's angle which is very vertical, almost 70 degrees. So I usually try to fix it with a DHS screw. So a single, the DHS is, the guide wire is placed like this. I usually like to put a cancellous screw superior to it. The osteotomy is just at the inferior level of the femoral neck, which is parallel to the DHS screw. A small wedge can be removed which allows for easy valgization like this. Once the valgus is achieved, then you can see that the Powell's angle has decreased. You can then put the DHS screw and fix it with the DHS plate. Usually valgus osteotomy, remember you should lateralize the shaft, only then will the mechanical axis be corrected. A case example, this was a 12-year-old female, known case of primary hyperparathyroidism. She had a fall with pain in the hip, but had to be admitted in the endocrinology department with severe hyperparathyroidism and was referred to us after 2 months. You can see that this is a stage 1 Sandhu non-union neck femur. In the abduction-adduction view, there is frank mobility. So as described by Sandhu's classification, this is a grade 1 fracture. You require just a good valgus osteotomy with a fixation, and you can see that at 1 year there is excellent healing and no AVN. What is the role of other advanced procedures? We always think of 2 main things here. One is the Mayer's or the Bakshi's muscle pedicle bone grafting, and second is the vascularized fibula grafts. Well, both procedures are extremely technically demanding. They are reported to have high success rate in those centers. However, they have been performed only in a few centers, and it still requires multi-centric trials for it. Thus, take home points for this. This is non-union neck femur is many a times an iatrogenic factor. Reduction and fixation is the most important cause. Sandhu's classification, so read this paper. Sandhu's classification provides treatment guidelines and prognostication. And in brief words, Sandhu 1, do a valgus osteotomy. Sandhu 2, do a valgus osteotomy with a fibula graft. And Sandhu 3, do a valgus osteotomy with fibula graft and fill the gap with cancellous bone grafts. Thank you very much.